This is Robert Casanova, and I want to thank you for participating in my study. In this instructional video, we're going to concentrate on acute abdominal pain in reproductive age women. This is often a very difficult diagnosis to make, as the signs and symptoms are often insensitive and nonspecific. Since this scenario can be life-threatening, we need to evaluate conditions like ectopic pregnancy, appendicitis, and ruptured ovarian cyst. We also have to consider fertility-threatening conditions like pelvic inflammatory disease and ovarian torsion. As a reminder, acute pelvic pain is pain that is less than 3 months in duration, and we're really going to be concentrating on pain with onset within the last 24 to 48 hours of the presentation. The differential diagnosis of this kind of pain is often divided by age and pregnancy status. For our purposes, we're going to be concentrating on women of reproductive age. Here is Table 1 from Krushka and Krushka, enlarged to include only women of reproductive age and the multitude of diagnoses that this represents. For the purpose of this study, we're going to concentrate on the more urgent or life-threatening diagnoses, namely ectopic pregnancy, ruptured ovarian cyst, appendicitis, and pelvic inflammatory disease. Most importantly, we're going to concentrate only on classic presentations of these 4 diagnoses. We understand that there's a variety of ways that any given diagnosis may present, but for your clarity and for this study, we're going to concentrate again only on the classic presentations. Let's take a close look at ectopic pregnancy. Let me give you a very basic explanation of the etiology of ectopic pregnancy. We're going to concentrate on natural conception, which is on the left side of figure 19. With normal conception, the sperm enters the uterus through the cervix and then travels through the body of the uterus and towards the tube, through the tube and towards the ovary. With ovulation, a mature egg is expelled from the ovary and picked up on the fimbriated end of the tube, and conception actually occurs in the ampullary portion of the tube, and the fertilized egg takes a few days to travel through the fallopian tube and implant in the body of the uterus. But what happens if the tube is scarred from previous endometriosis or infection? As you can see from the diagram, an ectopic pregnancy can occur in multiple places. It can be cervical, ovarian, abdominal. It can occur in multiple segments of the tube, namely the fimbria, ampullary, or the isthmic portion, or even in the corneal portion. But the most common is the ampullary area. So 98% of ectopic pregnancies occur in the tube, hence the name tubal pregnancy. Unlike the body of the uterus that can expand to accommodate a growing pregnancy, the tube cannot expand very much before the fertilized egg ruptures the tube. This leads to hemorrhage from the ruptured tube, and the sudden spillage of blood results in the sudden onset of symptoms from the peritoneal irritation. So let's look at the classic features of an acute ruptured ectopic pregnancy. The patient usually presents with menstrual irregularities, and she's often bleeding at the time of presentation. With acute rupture, the pain is very sudden in onset. So the first thing you're going to have to do is rule out pregnancy. Without a pregnancy test, the most important question to ask is, when was your last normal menstrual period? Emphasis on normal. A patient may have some bleeding that was a couple of weeks ago, but it was not at the right time or not the right quantity, so this would not be a normal menstrual period. The rule of thumb is, if her last normal menstrual period was more than 4 weeks ago, you have to rule out ectopic pregnancy. The other important question is, what form of birth control are you using? If the patient is using effective contraception like a vasectomy, a tubal ligation, an IUD, or birth control pills, then ectopic pregnancy is not 100% excluded, but it's much less likely. The most important factor in diagnosing an ectopic pregnancy is a high index of suspicion. So if a patient's last normal menstrual period was more than 4 weeks ago, it's your job to exclude pregnancy, and especially ectopic pregnancy if she has abdominal pain along with it. Now let's look at acute ruptured ovarian cyst. At the time of menstruation, multiple follicles are preparing for the next cycle. Ultimately, one follicle becomes dominant and reaches a size of approximately 2 centimeters. The mature follicle ruptures and releases an oocyte that awaits fertilization. This is called ovulation. When the follicle ruptures, the fluid contained in the 2 centimeter cyst spills into the peritoneum. Depending on the amount of fluid, it can cause no symptoms or symptoms of peritoneal irritation. What would happen if for some reason, and we're not going to get deeply into this, the follicle was larger and a large amount of fluid spilled into the peritoneum? What would happen if the rupture occurred at the site of a small blood vessel that continued to bleed, resulting in hemoperitoneum? This is the scenario that we will be considering in our exercise: spillage of a large amount of fluid or blood from the ruptured follicle, resulting in acute abdominal pain and the symptoms of peritoneal irritation. Since oral contraceptive pills inhibit ovulation as one of their major forms of preventing pregnancy, women who take birth control pills would be very unlikely to have a ruptured ovarian cyst. Probably the most classic symptom of an acutely ruptured ovarian cyst is very sudden onset, and although it can occur any time in the cycle, for our purposes we're going to have it occur during the time of ovulation. Often it is associated with intercourse or with very vigorous exercise. Now let's take a close look at appendicitis. The classic presentation of appendicitis is also that of acute pain, but it is much slower in onset than an ectopic pregnancy or a ruptured ovarian cyst. Classically, the pain starts in the periumbilical area and then moves to the right lower quadrant over McMurdy's point. It is often associated with fever, as the appendix ruptures and the infected material makes contact with the peritoneal cavity. This table from Cartwright and Knudsen shows the probability of certain symptoms associated with acute appendicitis. Obviously, there's a very high probability of right lower quadrant pain, but the next most likely finding is a migration of the pain from the periumbilical area to the right lower quadrant, and this is followed by fever. The rest of the findings are really physical exam findings, and they will be excluded from this exercise. Now let's look at our last possible differential diagnosis: pelvic inflammatory disease. Pelvic inflammatory disease, or PID, is a major health concern because it can cause long-term reproductive disability. It's particularly common among young, sexually active, and adolescent women. Acute PID is an ascending infection caused by microbes, usually Chlamydia trachomatis or Neisseria gonorrhea. PID generally begins as a localized infection in the cervix or cervicitis. Then there is a change in the cervicovaginal microenvironment that allows for the microbes to ascend into the uterus. Many feel this is facilitated by other infections or by menstrual flow, causing the major symptoms associated with this ascent of microbes from the cervix into the uterus to occur during or right after menses. The microbes then progress through the uterus and into the upper genital tract, through the fallopian tubes, and spill into the peritoneal cavity, causing peritoneal signs of infection, namely pain, guarding, and fever. Birth control pills work by thickening the cervical mucus, and this has the effect of preventing cervicitis from ascending into the uterus and into the fallopian tube. Therefore, women on birth control pills have a lower incidence of pelvic inflammatory disease. So the patient generally presents with a relatively sudden onset lower abdominal pain, and it's usually bilateral. As I previously stated, it often occurs during or right after her period. The patient may also complain of a vaginal discharge or recent bleeding that occurs between periods or after intercourse, and she may complain of recent painful intercourse. Severe PID is often associated with fever from the peritonitis. The rest of the findings are noted on physical exam and are beyond the scope of this course. Thank you for viewing this module and for participating in this project. These are my references. Again, thank you very much for your participation.